Um, okay. Okay. So, hello everyone. Thank you for joining our webinar series today. We are at the Arizona Center for Rural Health, a state office of rural health. And before I introduce our speakers today, I want to remind everyone of our housekeeping notes. Audience is muted during the presentation. Please enter your questions into the chat box. The webinar is being recorded and will be posted for future viewing. And also, we will appreciate your feedback. We are doing an evaluation survey in the end. And today we have two amazing speakers. We have Bianca SantaMaria and Raymond Valenzuela. Bianca SantaMaria has a master's degree in public health, works on the Overdose Data to Action State Program, OD2AS, at the Arizona Center for Rural Health, in the Maricopa Opioid Prevention Program at the College of Public Health. She leads the development and facilitation of overdose recognition and naloxone administration training, as well as program operations and coordination. She is an author on opioid stewardship program implementation in rural and critical access hospitals in Arizona, which was published last year. Her background is in substance use, clinical research, and health promotion. Bianca is pursuing her PhD at the University of Arizona. Raymond Valenzuela has a master's degree in public health, is a public health professional with more than a decade of experience advancing health equity, tribal engagement, and community-based research across Arizona. Raymond currently serves as a Research Program Administration Officer with the University of Arizona's Center for Rural Health, where he leads outreach and education initiatives focused on opioid prevention and response in tribal and rural communities. Raymond's career bridges academic research, public health program management, and tribal partnership development. With the Master of Public Health from A.T. Still University and a Bachelor of Arts in Mexican American Studies from the Arizona, Raymond combines a deep understanding of cultural context with evidence-based approaches to health promotion. His work continues to focus on improving health outcomes in Native and rural communities through collaboration, education, and data-driven public health practice. Welcome, Bianca and Raymond, and the floor is yours. Thank you.
Thank you, Rocio, for that introduction. Thank you, everyone, for being here. My name is Bianca, as Rocio mentioned, and I work for the University of Arizona Center for Rural Health. And Raymond, my colleague, will be presenting with me today. Today, we'll be presenting on emerging drug trends in Arizona, looking at Arizona's evolving drug trends. Next slide. Next slide. Okay. So first off, I want to respectfully acknowledge the University of Arizona is on the land and territories of Indigenous peoples. Today, Arizona is home to 22 federally recognized tribes, with Tucson being home to the O'odham and the Yaqui. The university strives to build sustainable relationships with sovereign Native nations and Indigenous communities through education offerings, partnerships, and community service. Next slide. So the Arizona Center for Rural Health partners with the Comprehensive Center for Pain and Addiction. The mission of the Arizona Center for Rural Health is to improve the health and wellness of Arizona's rural and underserved populations. As for the Comprehensive Center for Pain and Addiction, they are an innovative, diverse team of experts reimagining and transforming healthcare for pain and addiction. Next slide. I do want to say that Bianca, myself, and Raymond have no financial disclosures to report. And we do want to say that this project was conducted with funding from support of the Arizona Department of Health through the Centers for Disease Control and Prevention Overdose Data to Action states. Next slide. Okay. So after today's presentation, you'll be able to identify at least 3 specific classes of emerging drugs: nitazenes, novel benzodiazepines, and synthetic cathinones. You'll also be able to recognize common street names and marketing tactics used for these substances. Also, you'll be able to explain or understand why the mixing of opioids, fentanyl and xylazine, pose a unique challenge to standard overdose reversal protocols. Next slide. We pause to recognize all the people who have lost their lives due to accidental poisoning, substance use, misuse, and addiction, as well as their family and communities. We also recognize that millions of people are living in recovery or have resolved substance use challenges. Prevention, harm reduction, treatment, and recovery work. Substance use is often framed as a personal or public health issue. Today, we are expanding that lens to include all environments, because what matters is people, because people are the ones that need, this help and recognition most of their lives. A lot of people are under chronic stress and develop issues because they are unsupported or isolated. So our goal today is not to blame or control, but to understand and be supportive environments everywhere we are. Next slide. Okay. Okay. So first off, we want to recognize that Arizona is close to the border. So its proximity to the border, that's the Nogales, Arizona, Nogales, Sonora border, is a gateway. Since its proximity to the border, it is a primary hub for substance use transferring, specific for fentanyl, and methamphetamine distribution. Law enforcement in Arizona have consistently seized 50% of all fentanyl pills nationwide here over the last 3 years. So unfortunately, due to Arizona's proximity to the border, that's why a lot of the fentanyl is getting through here. That's why the prices are so low on fentanyl, due to the location. Next slide. Now we're going to talk a little bit about the trends. While the United States saw a 21% overall decline in overdose deaths in the last year ending September 25, Arizona experienced 17% increase. So this was only one of the 5 states with rising fatalities. From September 2024 to 2025, the 17% increase in overdose deaths was seen, as mentioned in the other, up on the quote I mentioned earlier. Fentanyl was reported as primary overdose deaths in Arizona, increased it by 30%, while nationally it fell 31%. So although we're seeing national trends fall in overdose deaths in Arizona, they are increasing, and they owe this, according to research, to the proximity to the border and the low cost of these substances. Next slide. So fentanyl is still involved in over 74% of non-fatal opioid overdose events in Arizona. The counterfeit pill, the M30, remains the main source. Also, in Pima County, the average price of an illicitly manufactured pill has dropped to as low as 30%. And the highest at-risk population is those individuals aged between 25 and 44, 25 through 44. And those are the ones at highest risk and who have, according to research, the highest rates of overdose. So not only we have the factors of proximity to the border, we also have the low price. I mean, 30 cents a pill, that's very, very, very cheap. Next slide. So Approximately 60% of all drug deaths in Arizona involve fentanyl. Fentanyl is now the deadliest drug in Arizona. The drug is frequently found in counterfeit pills, like I mentioned, the blues. They're disguised as prescription medications, and this puts an increase in risk for unintentional exposure. Because fentanyl is extremely potent and is often mixed into other substances, users might not know they are consuming it, which is another reason why overdose risk is increased. Next slide. So polysubstance use. Polysubstance use is the use of one or more substances in simultaneously or sequentially. Polysubstance use can occur intentionally, means they are doing it on purpose, or unwillingly or unknowingly. Overdose deaths often involve combinations of opioids, alcohol, stimulants, benzodiazepines, or synthetic drugs. So one of the very popular is mixing pills with alcohol or wine. And again, this higher your risks for an overdose. Next slide. In 2023, about 49.7% of non-fatal opioid overdoses involve more than one drug. So now, not only is fentanyl a leading cause for overdose, polysubstance use is also going up because of its popularity of people mixing drugs. So fentanyl with methamphetamine or amphetamines was the most common combinations. This trend is referred to as speedballing or stimulate opioid co-use. So that's becoming more and more popular and is on the rise, again, increasing the risks of overdose. Next slide. Okay. Here are some general trends through research that we were able to locate. So these were the highest fatal overdose rates per county. So it included Apache, Navajo, Pima, Gila, Mojave, Maricopa, Cochise, Yavapai, and Yuma. So of all of them, the highest was Apache County, and they had a 19.2% overdose rate, non-fatal. And the primary substances were fentanyl and alcohol. So those two mixed caused the highest overdose. As you can see in each of these, I'm not going to go through all of them. You'll have the slides after the presentation if you would want to look further. But as you can see, almost everyone, fentanyl mixed with something else. So again, polysubstance use is a high risk for overdose, and these are the counties experiencing those higher rates. So these are the counties as public health professionals that we should focus on assisting or targeting with our public health measures. So next slide. Okay. So here are some emerging trends. So besides fentanyl, the drug supply in Arizona is increasingly contaminated now with xylazine and high potency synthetic opioids like nitazenes, which make it even harder to detect and often resistant to standard overdose reversal protocols. So not only are these new trends making it harder to be able to detect them, they're also putting another obstacle in the overdose reversal protocols. So, and we'll explain that a little further in the presentation as well. Next slide. So as I mentioned, the rising threats seen here are xylazine, which is known as tranq. It's a veterinary sedative increasingly found in the fentanyl supply, and it does not respond to naloxone. Symptoms that people have reported are severe skin ulcers and heavy sedation, thus the risk for an overdose. Nitazenes, what should they call the Frankenstein opioids, is a class of synthetic opioids that appearing in Arizona that can be up to 100 times more potent than fentanyl. And then we have medetomidine, and it's a newer, even more powerful veterinary anesthetic, recently detected in the Western US supply. So that one's a little bit coming more from the East Coast, but it's coming this way. And it's something that's becoming increasingly popular. Next slide. Okay, so what these emerging drug trends, like I said, not only put a higher risk for overdose, but they also challenge the current overdose reversal protocols. So xylazine is not an opioid. Naloxone will not reverse its effects. If you administer it and the person doesn't wake up, it doesn't mean it didn't work. It means that the xylazine is still keeping their central nervous system down. So again, that one won't respond to it. Nitazenes, which are opioids, called the Frankenstein opioids, require multiple doses of naloxone. So otherwise, opioids, you say one dose of naloxone, possibly two. With this one, it's been found to require at least 3 or 4 doses just to restore basic breathing. So again, this poses now with these emerging drug trends. Now, if they're using nitazenes and that becomes more increasingly popular, now instead of saying carry 1 box of naloxone, you're going to have to carry multiple in order for it to work. So again, becoming more of a challenge, and making sure that the naloxone supply is increased everywhere. Next slide. Okay. So a little bit more about these emerging trends. Again, summary that xylazine is a non-opioid sedative. Nitazene is an ultra-potent synthetic opioid. Xylazine is resistant to naloxone. And nitazene is naloxone responsive, but requires a significantly higher dose. And xylazine has been detected in an increasing number in Maricopa counties and Pima County as of toxicology reports of 2025. And nitazenes are emerging in the Southwest, so it means they're coming. Not as high as xylazine yet, but they're harder to detect than the standard fentanyl as mentioned. Okay, so this is just a thought for yourself. You don't have to answer it, but as we proceed with the presentation, just a question for you to think about. When an illicit M30 pill, the fentanyl pill, costs only 30 cents, it's less than a single dose of over-the-counter pain relief. How can our prevention messaging compete with that level of accessibility? Again, it's not for you to answer, just something for you to think about and reflect on. Next slide. And these are some other emerging trends. These are coming from the East Coast. And again, they're slowly being seen here. So tianpatine, the gas station heroin, as they call it, is an antidepressant opioid often sold in convenience stores as a cognitive enhancer. So you might have seen when you stop at the gas station and you see, oh, enhance, no more energy, cognitive enhancer. This is becoming more and more popular, especially by the truck driver population, according to research. And they're taking it, and it's also a higher risk for overdose. Another one that is increasing is synthetic benzodiazepines. So counterfeit Xanax and Valium are also increasingly being used to cut other drugs, which complicate medical treatment. And there was an important trend noted in the youth. So a shift in Generation Z toward cannabis, psilocybin, and ketamine through counterfeit pills also remain a higher risk for accidental poisoning. So these are new and upcoming trends that we are seeing emerging mainly from East Coast. Next slide. So again, here are some common street names and some marketing tactics. So nitazenes are known as isotone, proton, yellow M30, and the Frankenstein opioid. They're often pressed into counterfeit oxycodone, so the M30s, or into Xanax bars. They are marketed on the dark web as a potent fentanyl alternative. Xylazine tranq, as it's called that's known as street names of trank dope, sleep cut, zombie drug, Anastasia. So they are also marketed as a way to lengthen the high of fentanyl. They're distributed primarily as a white, tan, or purple powder mixed into the opioid supply. So novel benzodiazepines are called Hulk bars, green, yellow buses, stickies, or liquid Zan. And they're also sold as press pills that look identical to pharmaceutical grade, but contain unregulated analogs like Flua, Lysol, Prolazam, and other medications. Also, synthetic cathinones. So these are bath salts called bath salts, Flocka, monkey dust, Molly. They're often sold as colorful crystals or powders, sometimes marketed as jewelry cleaner, plant food, to bypass traditional legal detection. So again, here are some common street names and marketing tactics. You'll have access to this after our presentation. Next slide. So now that we've talked about some of these emerging trends, the protocols with naloxone, what else puts you at higher risk? So using alone and mixing substances. Polysubstance, as we mentioned earlier. So when they mix alcohol or benzos, and using alone. So not having anybody there in case you have a reaction, you counter an overdose to call for help. Using after a period of abstinence. So somebody who's been in the hospital for a long time, prison, jail, then comes out and uses drugs, they have a lower tolerance. So this puts them at higher risk for an overdose. Also, the power of potency. So the rise of synthetic opioids, like we've talked about, like fentanyl, has made doses unpredictable. We really don't know how much fentanyl is in these drugs that they're selling, what they're laced with. So again, another higher risk for an overdose. So best prevention tip that we can say is never use alone and always, always use fentanyl test strips. Next slide. And now my colleague Raymond will take on the presentation. Thank you.
Thank you, Bianca. Okay, we're going to talk about stigma in culture and language. First off, stigma isn't limited to policies or formal decisions. It often shows up in everyday interactions. It appears in our language, our tone, and in the way we talk about people when they're not present. One example is using person-first language, saying a person experiencing substance use challenges rather than defining someone by a behavior. This approach reminds us that individuals are more than a diagnosis or a single moment in their lives. These shifts in language may seem small, but they have meaningful impact. Research shows that when people feel psychologically safe, that is, when it feels safe to simply be human, they are more likely to seek help, stay engaged, and remain connected. The way we speak, listen, and respond to someone who is struggling truly matters. Culture doesn't change all at once. It evolves through consistent moments of care, respect, and accountability. Next slide. We're now shifting into overdose awareness, and I would like to make something clear here. This is not about blame, fear, or responsibility. It's about safety and preparedness. Overdose can happen in many environments, including workplaces, not because people are careless, but because substances today are unpredictable, and many people are navigating pain, health conditions, or stress alongside their work lives. Federal agencies like the Center for Disease Control and Prevention and the National Institute for Occupational Safety and Health approach overdose awareness as a safety issue, similar to CPR or first aid, not a moral or disciplinary one. The important lesson here is that awareness helps reduce harm. When people know what overdose can look like, they are better able to recognize an emergency and respond appropriately. Next slide. Okay. Recognizing overdose and responding with care. Simply put, an overdose is a medical emergency. If you suspect an overdose, your role is to recognize the emergency and call for help immediately. Naloxone is a medication that can reverse an opioid overdose by restoring breathing. It is safe, not addictive, and has no effect if opioids are not present. Many states, including Arizona, allow naloxone to be purchased over the counter, and public health organizations provide clear guidance on how to use it safely. Next slide. Signs of an opioid overdose. This slide summarizes the common signs of an opioid overdose. You don't need to memorize these, and you don't need to be perfect at recognizing them. The goal here is familiarity, so that if something feels off, you trust that instinct. So, some of the signs may be being unable to wake up, unresponsive to stimuli, changes in skin, lip, or nail bed color. This is an important one because oftentimes we hear that if you see someone with blue or very, very pale lips, that could be an overdose. And while that's true, it's not universal for everybody. And by this, I mean it really does and can depend on a person's complexion. So a person of light or medium complexion may showcase or display blue or very pale lips, gums, or fingernails. A person of brown or black complexions may have instead gray, ashen, or whitish lips, gums, nail beds, or inner eyelids. If you can't tell with a person, other ways you can tell are by checking the inside of the lower lip, tongue, nail beds, and the conjunctiva here in the eye if skin tone makes color change hard to see. You can also experience very limp body, slow heartbeat, slow irregular breathing or the absence of breathing, choking or gurgling sound, and also pinpoint pupils. These signs will be reviewed in more detail in a video we'll see soon. If you remember nothing else from this slide, remember this. If someone won't wake up and their breathing seems off, it's okay to treat that as an emergency. Next slide. Okay, here are the steps to take if you suspect an overdose. Sternum rub. If you have no reaction with that, call 911 and administer naloxone. Rescue breathing, if you feel comfortable doing that, follow 911 dispatcher instructions. I want to emphasize that calling 911 is part of care. It's not about getting someone in trouble. It's about keeping them alive. After naloxone, stay with the person for at least 3 hours or until help arrives. We are now going to watch a lay video on how to identify and respond to an opioid overdose and administer naloxone safely from Dr. Melody Glenn. If we can do the video, Rocio.
Okay, give me 1 second. Almost there.
I'm Dr. Melody Glenn. I'm an emergency medicine, addiction, and EMS physician with the University of Arizona Banner. I also volunteer with Cochise Harm Reduction. Today I'll be showing you how to use naloxone to reverse an opioid overdose. Naloxone is a nasal spray that is used to reverse an opioid overdose. Naloxone can restore normal breathing in a person who is overdosing on opioids if administered in time. Naloxone will not have an effect on someone who is not overdosing from opioids, so there's no need to worry about this. If you think someone is experiencing an overdose, check if they are responsive. Lay the person on their back. Make a fist with your hand, press, and rub your knuckles along their breastbone while shouting for the person to wake up. Wake up! Apply pressure. If the person does not wake up, have someone call 911. Remove the nasal spray from the box. Peel back the tab to remove the device. Hold the naloxone spray with your thumb at the bottom of the plunger and 2 fingers on either side of the nozzle. Do not test the device. This will release the medication. Tilt the person's head back and provide support under the neck with your hand. Gently insert the tip of the nozzle into the nostril until your fingers on either side of the nozzle are against the bottom of the person's nose. Press the plunger firmly to give the dose. Remove the spray device from the nostril. Begin a timer for 2 minutes so you know whether a second dose will be needed. If needed, and if you are trained, provide rescue breathing. Follow the 911 dispatcher's instructions. If there is still no response from the individual after 2 minutes, give a second dose of naloxone in the other nostril using a new spray device. If the person starts to wake up, place them in the recovery position. They may be experiencing opioid withdrawal and may feel very sick. Explain to them that they have just experienced an overdose. Help them get comfortable. Don't leave the person alone for at least 2 hours. Naloxone is temporary. It will last from 30 to 90 minutes. It is important for someone to stay with the individual for a couple of hours or encourage them to go with medical transport. Naloxone only works on opioid overdoses, not on any other kind of drug. Naloxone is safe to use. It will not affect someone if they are not experiencing an opioid overdose.
Thank you, Rocio.
Thank you. Let me get the
Presentation back up.
presentation. Yes. Can you see it? No?
Not yet.
Okay. Hi. Can you see it?
Coming up. There we are. Yes.
Okay.
Thank you, Rocio.
Okay.
And thank you, everyone, for your patience. Next slide. And next slide again. Okay. Thank you again. So, possible effects of naloxone. As we just saw, there are some possible effects with naloxone. A person, for instance, may become irritated and react. Give them space if needed. Their body might feel like they're going through withdrawals and are having an extremely painful flu. Give the individual space after you use naloxone on them. They may feel sick, throw up, or experience side effects such as the ones on this list. Withdrawal is very painful, so be gentle and say you overdosed and we used naloxone. Take a second to breathe. Next slide. So what can be done? Well, for one, we can expand drug checking by distributing test strips that identify both fentanyl and xylazine. Focus mortality prevention efforts on that 35 to 44 age demographic, while at the same time focusing non-fatal intervention at the lower age group on education for 25 to 34. We can increase naloxone in high mortality rural counties to compensate for longer EMS response times. Prioritize resources on high mortality rural zones, and again, that 35 to 44 age demographic. We can also move the conversation beyond just fentanyl to include meth, xylazines, and nitrazines. Next slide. These are some places where you can get naloxone statewide. If you are interested in naloxone access in specific Arizona counties, please let me know, and I'm happy to get you that county-specific naloxone resources. Also of note, pharmacies, for example, Walgreens and CVS, typically can dispense naloxone without a prescription. You just want to check with them ahead of time to make sure that they have available stock. Next slide. So after an overdose, care doesn't end once the immediate emergency is over. And in workplace settings, that care looks a little different than it might in clinical or emergency roles. Your role is support, connection, and respect. Support can start with simple, open-ended questions like, how would you like things to be different? Or what kind of support would be helpful right now? Showing that you are listening without judgment, pressure, or urgency can make a meaningful difference. Help with locating a treatment center, connecting them to peer support or community resources, or looping in appropriate support systems. It's also important to reinforce that asking for help is okay, and that needing support does not define someone's value, professionalism, or ability to contribute. And follow-up matters. Checking in, even briefly, can help people feel seen and supported rather than isolated. And finally, I want to name the impact on those who respond. Witnessing or responding to an overdose can be upsetting. Take time to ground yourself, debrief with appropriate supports, or step away if needed as part of care. Supporting others includes supporting ourselves. Next slide. So some key takeaways. The first key takeaway being Arizona is an anomaly in the national trend. The synthetic supply in the southwest border region remains accessible and affordable. Number two, a polydrug era has emerged where synthetic opioids are frequently mixed with stimulants and non-opioid sedatives. Third, the emergence of xylazine and nitrozenes require modified overdose responses, making higher overdose risk. And also, number four, there is a rural-urban divide. Rural counties tend to have higher mortality rates due to the lack of immediate access to naloxone and emergency services in remote areas. Next slide. Wanted to present a closing discussion, kind of something to think about as we did earlier. Think about this. If we could place naloxone, if we could place a naloxone kit and fentanyl xylazine test strip in every household in Arizona tomorrow, what is the one barrier, besides funding, that will prevent people from using them? That's, again, just something for us to think about and necessarily have to answer it, but it is one of the challenges if we think about this enormous problem we have. Is there easy solution? Next slide. Finally, we'd like to thank you all for participating in today's training provided by the Arizona Center for Rural Health and the Comprehensive Center for Pain and Addiction. We now invite you to answer these questions that you can find on this QR code or on the link here. If the link isn't accessible from your screen, we will provide it at the end of this presentation here. But we really do appreciate your time to answer these evaluation questions because they do help us with our programming. Please, everyone, go ahead and continue doing that. Next slide. And again, thank you from myself, my colleague Bianca. If there's any questions or you'd like a training for your department, organization, feel free to email us and we will get that ball rolling. For resource questions, please email our other colleague, Estefania Mendeville, at the email you see there.
Yes. Thank you, Raymond and Bianca, for this great presentation today. We have a couple of questions in the chat, and we still have some time to answer these questions if you could. The first question is, there seems to be a stark divide between the proportion of fatal to non-fatal overdoses recorded in urban and rural counties, while urban area having significantly more non-fatal. Do the presenters have an interpretation of these findings?
Yes, I can answer that one. Thank you, Rocio. So the reason we see this divide between rural and urban is because urban has, hospitals everywhere. They can go and get help if somebody's encountering an overdose right away. In rural counties, some of them, like let's say, they live an hour away, 2 hours away from a hospital. So accessibility to these hospitals or emergency centers in the time of an emergency, of an overdose, they are not getting there on time. Although the numbers are getting better because, we're more distribution of naloxone, more availability of that. But again, I think those differences are because of the lack of emergency centers or, EMS assistance. EMS will take a long time to get to them, depending on where they live.
Thank you, Bianca. We encourage everyone to keep sending the questions in the chat. We have another question too. What are the current mechanisms to monitor the contents of the street drug supply in Arizona? And the follow-up question to that is, how are these findings communicated with impacted populations?
Current
Do you want me
mechanism.
to answer, Raymond, or do you want?
You know what? Yeah, this one I'm gonna let you take this one.
Okay. So current mechanisms that we have, Arizona Department of Health Services has a website. I'm not sure if we provided our resources, but they kind of monitor what drug supplies are coming in and out. Overdose, they have a page dedicated to overdose, keeping track of how many are reported. Different counties have different tracking systems. I'm also aware that in Santa Cruz County, they work with the police department and they kind of monitor the street drug supply as much as they can and kind of report to on overdoses reported in that specific county. The DEA, Drug Enforcement Agency, also has a monitoring mechanism in place. Again, we can access those things on their websites. They do reports in which they kind of let us know what drug supplies are currently in Arizona. That's how I was able to do research and find out what emerging drug trends are occurring here. So those are the different mechanisms that currently exist. And I think, how they are communicated with impacted populations, I think we need to do a better job at that. I mean, like today we're doing a presentation on what emerging drug trends, but I think we need to get this information more into those populations that are more at risk. Kind of looking at what counties are more at risk, what age groups, focusing on those, because the information is available, but I'm not sure if all the people are going to take the time and have the knowledge and ability to go on the websites and look for those reports or see. I don't think it's readily available like something that we have. Oh, these drugs are being seen higher risk. I know the news reports, but minor reports. So I think that's something that we need to improve on, having those findings communicated with the impacted population. So that's a very good question. And I think that's something that we definitely need to work on because the information is there. But is it getting accessed by those impacted populations? I am not sure.
Thank you, Bianca. And we have another question too. Can you speak to legal protections for people administering naloxone, especially for people that might be afraid to call 911 due to presence of paraphernalia or immigration concerns?
That's a great question. So first off, We're not attorneys, so I can't offer legal advice, but there is something called the Good Samaritan Law. And basically, it states that you can't be prosecuted for basically doing the right thing. So in this case, if you were to see someone that you recognize is experiencing an overdose and you were able to administer naloxone, I understand the fear that people may have, especially when we make it a little more complicated when we start talking about immigration concerns or even presence of paraphernalia. But as it stands, typically, a person's not asked about their legal status when they're helping out an individual. When EMS or emergency services is able to come to the individual that's experiencing the overdose, their priority is to save the life. You as the Good Samaritan have already started that with the administration of naloxone, and assuming that the person is responding well, and they've now come to you. From that point, it's just what's the next steps? Are they transported to the hospital, or where it goes from there? But typically, there's not a lot of there shouldn't be a lot of concern when in acting and doing the right thing. But good question.
Okay. Thank you, Raymond. We still have a couple of minutes for everyone to share more questions. And also, please take the survey. We appreciate your feedback. That's how we improve our content. And I am checking the box, and it looks like we don't have any more questions. Any last thoughts, Raymond, Bianca, before we close today?
Go ahead, Raymond.
Ladies first.
Well, I just want to say those were excellent questions. And I think that brings awareness to really what we have to focus on, making this information accessible to the populations that are most impacted. So I think I love that that was brought up. I wish we could have more discussion about that. But I think even attending these types of trainings and becoming aware makes a difference, because you become aware, you tell somebody else about it. Maybe some flow will get going where we have this information and make it more accessible to everybody. But thank you, everybody, and that's all. I'll pass it to my colleague.
Thank you. I would like to also reiterate, thank you everyone for attending this webinar and for the questions that were asked. If this information was new or even a little bit scary to you, I would say, the first step is to make yourself more educated on the material and on this topic. Encourage you to please visit the Arizona Center for Rural Health website if you're able to. And there's a lot of information we have there. We have information as well on different resources throughout the state. And we just encourage everyone to just be aware. It saves lives. Thank you.
Yes. Thank you, Bianca and Raymond. And for our audience, we have their email addresses on the slide. So please do not hesitate to reach out to them for any further questions, recommendations, and perhaps resources as well. The OD2A email address is on the website as well. If you are interested in the work that OD2A does, please visit the website as well or send them an email. They will be happy to respond to any questions that you may have. Without any further ado, we don't have any more questions, so I think we are ready to go.
Thank you very
Thank
much,
you,
Sophia,
everyone.
for hosting us, and everybody for being here. And thank you, Mariah, as well.
Thank you, everyone.